thank you for joining me and taking time out of your busy schedule and wanting to take extra steps to get prepared for this term. Please let your colleagues know that if they didn't get to attend tonight, the presentation would be available through iLearn, typically in about 24 to 48 hours after the presentation. I will also be doing one, let me see what it is, in a few weeks for the midterm exam. The 7th? Yep, February 7th at 8 p.m. will be for the midterm exam or content review. And then again, can you guess here? On April 9th at 8 p.m. Eastern for the final exam. So I encourage you to come back and join me again for those chats. I have a chat box open, so if you have any questions at any point in time, don't hesitate to put it into the chat box. I have 3 screens so I can see your questions coming in. And then we'll certainly have plenty of time to answer questions too at the end of this. So here we go. So first off, can you see my screen okay? And can you hear my voice okay? Perfect, okay. So the plan for the evening is to identify common challenges that students tend to experience in this course. Now I mentioned I teach this both residential and flex, and so that means I teach this class 5 times a year for the past gazillion years. So I have a bit of an idea of what comes easy, but also what comes more difficult. And then some study strategies, skills, habits, routines that will then make you successful in this course. So, starting with the lecture information for this course, it is critical that you have an honest conversation with yourself of what content you know and what you don't know, or what content you don't know as well as you need to know. So really applying to your foundational knowledge of anatomy and biomechanics that you've learned in prior courses. You are coming, my expectation, our expectation as faculty is you're coming into this course with a very solid knowledge of anatomy and biomechanics. So therefore we can start applying that information to new content. So if that content has been tricky for you in the past, or maybe the foundation wasn't quite as solid as it could have been, this is your opportunity to solidify, because you are treating humans. Humans are made with the same insides in terms of anatomy and how they're built. For the most part, we do have some unique differences, but in general. So by you understanding how many bones make up each segment, how many facet joints on each surface, what's the orientation of the facet joints in each region of the spine, why is it different? How does the difference in the facet orientation contribute to the differences in available movement? How many of those joints, how many are synovial? Why does that matter? Answering the question of what is a motion segment, right? Because we as PTs don't treat bones, we treat motion segments. So a motion segment is the bottom half of the superior vertebrae, that includes the facets, the disc, and the superior half of the inferior vertebrae. And that's a motion segment. So always we're talking about motion segments, we always talk about 2 numbers. So instead of saying like just L1, we would say I'm assessing L1/L2. Because we're feeling the movement segments. We never know exactly for sure where the movement is. We can know within that motion segment, but in terms of, are we feeling the motion on the right side or the left side? We don't know when it comes to the lumbar spine because it's too deep. Another great question is, what is an intervertebral disc? How many do we have? Why is it made the way it's made? How does it change throughout the lifespan? Is it different in the cervical versus lumbar spine? How is it different? So all of those bits of information you should have some knowledge on already. And so the beginning of this course, you're really building upon more of that knowledge and getting it stronger and more comfortable with that knowledge. If these are things you're unsure of yet, go use some homework to do. Start answering those questions. And be prepared for us to always ask you the why or tell me more about everything for this course, because we really want to get at your critical thinking, your clinical reasoning, and your problem solving. To me, the answer of because you said so, even if it's because Dr. Grant said so, terrible answer, terrible answer. Give me more, help me understand your thought process behind it, okay? So building on some of your foundational knowledge of anatomy, what muscles attach in the region of the spine and how do they relate to spine dysfunction and spine rehabilitation? And you'll be getting more of this later on, especially from a treatment perspective. But from an attachment perspective, you should know this. You should know innervations. You should know muscle function. And then start to ask yourself the question of why is it important to know about the muscles in the spine and their attachments, and how do they respond to dysfunction? We know in the low back, when there's been an injury and someone has pain, their multifidi start to shut down in a very short amount of time and don't automatically turn back on. Your knowledge of that is a huge defense as to why you should be working with these patients with low back pain, even from the beginning, because you can help mitigate that muscle atrophy from setting in. Okay, so start to dust off your anatomy and biomechanics notes, flashcards, things like that. From another lecture perspective, from basic neuroscience, understanding your neuroanatomy. So understanding where the cord is in the body, where it ends. Remember, the cord ends at approximately T12, L1, L1, L2. It doesn't go below that. You've caught a equina below that. Understanding the terminology we use to describe different types of nerve input. For example, dermatomes and myotomes, right? We know dermatomes are areas of the skin that are innervated by a specific nerve root, whereas myotomes are muscles or groups of muscles that are innervated by specific nerve roots. It's very, very specific as to what pattern we see. Whereas peripheral nerves are going to be much more distal to your nerve roots, simply much more specific for a muscle or a very specific sensation on the skin. It's critical that you know your dermatomes, myotomes, neural tension, and reflexes for all spinal nerve roots. So I recommend having a list up that run through those, either on your bathroom mirror, so when you're brushing your teeth, you can go through them. If you have a water closet where your toilet is, stick it on the inside of the door, so the door is shut, and you can sit and go through your dermatomes and myotomes. Any way you can make it so it's commonplace, do the dermatome myotome dance, whatever you need to do to help you get this in. Because, and this is, all of this stuff is not just for this class, but boards, and then more importantly, and most importantly, clinical practice in your patients, right? Because I expect to see direct access increasing more, and you're going to be seeing patients that are coming, you haven't seen anybody else, and you need to be able to be thorough in your diagnosis, and then know what you're finding, and then know how to recommend treatments based upon what you're finding. Also, thinking about nerves, it's important that you understand the difference between upper motor neuron and lower motor neurons. And you may not have got to this yet so far this term, and that's okay, or the review of it this term, but this is an area that totally messes people up, and I don't understand why to this day. Upper motor neuron, does that refer to what tissue is involved if someone has positive upper motor neuron presentation? What tissue in the body? And there's never a dumb answer in this type of setting, in my opinion. Okay, so we're gonna make this we're gonna give you two options. You'll tell me which it is. Is it, would upper motor neurons, so hyperreflexia, be positive in the case of a nerve root injury? Or would they be positive in the case of a brain or spinal cord injury? Who says nerve root? Hands up. Who says brain or spinal cord? Hands up. Yay, good. Okay, so upper motor neuron means you're checking the integrity of the brain and spinal cord. So a positive upper motor neuron reflex would be hyperreflexia in general, but also your pathological reflexes, upper motor neuron reflexes, would be Babinski, Clonus, Hoffman's inverted supinator. Okay. Lower motor neurons are the reflexes associated with nerve root examination, you could say. Lower motor neurons, when those nerve roots are injured, present with hyporeflexia. So that's going to be your typical triceps, biceps, brachioradialis, patellar Achilles reflex. And if the nerve root has been injured, those would be hyporeflexive, so less bouncy, or even absent maybe. You may be able to think of upper motor neuron. Typically, that's going to be someone who has a brain or spinal cord injury, potentially an incomplete spinal cord injury. That's going to give you that hyperreflexive presentation. I highly recommend just going onto YouTube and looking for patient presentations with positive upper motor neuron signs, specifically Hoffman's inverted supinator Babinski, Clonus, Hoffman's inverted supinator. Look at those 3 or 4, and then since you haven't seen a patient like that yet, then it'll be like, oh, that's what that looks like. And then the first time you get a patient who has a brain or spinal cord injury, check those reflexes. Be thorough, just check them. So then you can feel the clonus and you'll be like, ah ha ha, because clonus is hyperreflexia, right? There was something else that made me think of. It'll come back. Oh, brachioradialis reflex is the same, that type of test you do is the same test that checks inverted supinator. Same place, same reflex, just a different response. Positive inverted supinator would be the hyperreflexive presentation of the flexing of the fingers for brachioradialis versus flicking of the elbow. It just looks totally different. But YouTube it. And I think the ones I typically go to are OrthoPal. Can't remember his name. My colleagues that were with me on Saturday. What was his name? OrthoPal. Paul. He's a therapist. I don't know him. I have nothing personal. I don't know him. I don't make any money off of him, but he just has, it's a clinician who does real clinical stuff and records some videos. I'm not talking about his quality of his exam, but just he has really cool videos that show you what it looks like. So that can make it easier since you haven't had a chance to see it yet in person. So on tests, on the oral, on the written exams, no one tell me if someone has nerve root involvement that they're hyperreflexive. Don't do that, right? Nerve root, hyporeflexive, lower motor neuron. Brain cord, so myelopathy, hyperreflexive, upper motor neuron. Okay. I promise you will see this in many different ways coming at you on tests, especially on the boards. So here's your list of your dermatomes and myotomes, and for upper and lower quarter. Now, keep in mind that you're going to see tons of these different charts. I think what's a great resource would be also your Olson text for this. It gives a really nice breakdown to show the presentation. These are the most common, but know it's a bigger area than just a muscle or a certain space. So it's more expansive than that, okay? Here's your upper motor neuron reflexes I spoke about, as well as your lower motor neuron reflexes. So remind, hyperreflexive upper, hyporeflexive lower. Maybe say like in a squeaky voice. Upper motor neuron is hyperreflexive versus lower motor neuron is hyporeflexive. It's been a long day. We're getting punchy here at 8:16 in the evening. Okay, so during this course, you are going to be learning how to conduct a thorough yet concise patient examination, including the history of the patient. And based upon your history, you should be able to hypothesize what may be going on with your patient, and then identify what tests and measures you should be doing and conduct that examination to best identify the impairments that are impacting that patient. You'll be needing to explain and demonstrate steps of your examination, including tests and measures. And in doing so, you're going to need to be able to talk about and explain where your hands are with the different techniques, what your hands are feeling with the different techniques. For example, there will be some techniques where you are palpating in the lumbar spine, and you will be palpating on the lateral interspinous space to feel the bottom spinous process move under the top spinous process. So essentially, if this is the top spinous process, the bottom, you're feeling for this guy move. Your fingers over here, palpating. I need you to be that clear with me as to where your fingers are. I'm on the lateral interspinous space of L3-4, feeling for the bottom spinous process to come into my hand. That's all. And the cool thing is, just do the motion, do it on your patient, and you can actually feel it. But just be clear. I can't assume what you insinuate. Okay. Explain the findings of the examination and what it means to you. What is the so what? What's the takeaway? What do you do with that data? Is that data so general you have to do more tests and measures, which may be the case? Or is it specific enough that you can start treating based upon that impairment? For example, active range of motion is a very general, non-specific assessment. It's a very important assessment, but it doesn't tell us what tissue, if it's impaired, that we need to treat. We have to do more tests and measures to determine what tissues we actually have to treat, right? Be able to give your why for the tests and measures that you're doing, and the why for the interventions you're going to be selecting. So if you found this active range of motion limitation, you found your joint mobility assessment to limit in this direction, you decided to do this treatment, connect the dots, connect the arthrokinematic dots to make it make sense as to the why behind what you're doing. Please be sure you can identify spine-related syndromes in using the ICF and CPG classification based on the patient presentation. Before this session, I was on an information session with Stephen George and Jason Benechek and a bunch of other cool researchers, and they were talking about like the use of the ICF model and CPGs and how it's used. And they gave a really good analogy because it kind of came this like back and forth debate about one doesn't like the term cookbook, one does like the term cookbook, but not because it is something you have to specifically follow, but because typically when you use a cookbook, you start to modify the recipe based upon the audience or the people you're going to be feeding the food to, which should be the same as how you use your clinical practice guidelines in your patient care. You know the general outline of what is the best to reach the desired outcome, but you're going to modify it and tailor it depending on who is in front of you. Like, oh, that person does not like spicy pepper, but typically you would put spicy pepper in that recipe. But because of the audience you're giving it to, you're going to modify and you're going to change it to fit that person. That's how CPGs are intended and should be used. They're not it says this, I do this. That's clinical research is only one of our pillars of evidence-based practice for our patients. And we need to remember that. Lastly, you'll be creating treatment plans and exercise progressions for different spinal-related dysfunctions. And I'd be expecting to find, like, on exams coming up. So your patient was just diagnosed with XYZ diagnosis. What are your initial interventions you're going to start to do? Okay, they're now in the chronic phase. How would your treatment differ? And we're going to be giving you all that information. We're going to be teaching you about that. But just be prepared to be able to do that and progress a patient. Because when you go on internship, you may be seeing patients in all phases of recovery, and you need to be able to maybe step in and provide care for them depending upon where they are in their recovery journey. Ways you'll be tested in this class, through practicals, through some form of oral exams, through written exams. The hardest, I would say, is truly oral exam in any capacity, because you lose all the ability to have any notes in front of you, including like written exams, multiple choice exams. Yes, they're tricky, but also they're easy in that the answer's in front of you. You just got to figure out the right one, right? But the answer is like really looking at you. Oral exams, it's all up here. There's no song and dance. You can't work your way around it. So the trick to get comfortable with being uncomfortable is to start talking out loud now. Explain anything spine related to anyone or anything that will listen. A pet, a plant, a rock, anything at all. Start talking out loud, because you're going to hear yourself talking out loud, and that's going to connect different spots in your brain and help to make it make sense. Then start practicing talking to someone who knows what you know, or maybe a little bit more, so they can start challenging you on what you're saying. And a simple way to challenge is tell me more, to make sure they're going to the depths that are necessary. You should be able to teach this content in this course to other people. That means you know it well enough. It truly does. And that's really true for any of your courses here. Work with classmates you can be vulnerable with. I am an alumni of the university from way back in the day when there was only the St. Augustine campus and the big building wasn't there. We were in trailers. So eons ago. And there were classmates that I knew I could work with for spine that I could not work with for other classes, because they knew so much more than I did that when they started talking and studying, I felt dumb and stupid. And my brain like shut off and walked out the door. And it was an hour of wasted study time, because I was just sitting there going like, I don't know what they're talking about, and I don't know this. And so find the right study groups for this class. So people that you can be vulnerable with, you can show them your weaknesses, and they're going to politely tell you, no, you're not quite there yet, but they're going to also work with you and help you get there. Then push yourself to work with other people, because we know that when your stress goes up, your brain function goes down. We know that, we see that. And so you've got to practice to answering questions in stressful environments, so you're used to performing at that level. It's like when you think about basketball players, for example. You may be a brilliant free throw shooter when the gym is silent. It's only you. You can make every single free throw, nothing but net. But it's clutch time, state championship. You've got to make these two baskets to win, and all you do is airball because you're so nervous. There needs to be that carryover. So you got to practice in those stressful environments to get more used to performing that way. So with the resources that you have for yourself, use your textbooks. The Manual of Physical Therapy of the Spine by Ken Olson is a fantastic book. He was was the first fellow for the University of St. Augustine. He was trained by Dr. Paris. Therefore, their language is the same. So the same techniques you're going to see in the S1 manual. There may be more descriptions, and there are more tests in the Olson text than there are in the manual, because he's elaborated further. But both resources are fantastic. And then utilize the foundations of clinical orthopedics. If there's stuff in your knowledge of anatomy and biomechanics and the foundational stuff, you're kind of like, I don't quite know that. That becomes a great book to use, your FCO, the white book with the teal. Read and utilize your required readings for this course. And then dust off any, tell Brian hi. Utilize other resources. So anatomy and biomechanics texts, movement science texts, anything, dig it up. I do know that there are study guides that are running around. Some are good. Some are good notes. Some are absolute trash. And I know when people are in testing environments, especially for orals, had their hands on garbage study guides because they're making absolutely no sense. It's like mumbo jumbo. I'm like, what are you saying to me? Like, for example, you'll be learning later on about mechanoreceptors. And There are 4 different types of mechanoreceptors. One is nociceptive, which means it senses pain, right? And most of our body has type 4 nociceptive mechanoreceptors on it. It can feel pain. It's a good thing, keeps us safe. But there's some areas in our body that do not. Based on your knowledge of neuroscience, you happen to remember what parts of your body can't feel pain. Do you know? You have not had this yet in your lecture for this course, but just thinking about do you know? I think I read a study saying factors are supposed to make you wait like 2 minutes before I interject, so I'm going to make you wait a little bit longer, make you think. Brain, spinal cord, dura mater, cartilage, articular cartilage, hyaline cartilage, nucleus. You can't feel. So that's a good thing that your articular cartilage can't feel, right? Because if your articular cartilage, if the cartilage that covers your bones, your long bones, could feel, we would just be yelling all the time because we'd all be hurting with every single movement we did. But the reason why, when someone has osteoarthritis, their joints start to hurt is because the cartilage has worn away. The protective coating has worn away. So therefore, bone underneath can feel. So I say this because there's a study guide running around that says the skin on the forehead is not innervated. They're saying it doesn't have type 4 mechanoreceptors. If you tell me that, I know you've been studying garbage, and I'll make you flick yourself in the forehead and ask you, does it hurt? Okay, so just test the study guides that you have to make sure they're not full of garbage. Or I would say, my opinion, work with your peers now to build a new study guide. That way you know for sure it's correct. Then because that I think is part of the knowledge building process, is actually building the study guide, right? And to me, thinking about oral exam type questions and how you could be asked questions, really almost every single square for every PowerPoint in the online, VOPPs, S1 manual, etc., could be turned into an oral exam question. So think of questions you can create to ask your questions of yourself to build that study guide for yourself. Okay. So based upon that, I'm going to stop sharing so I can see you better. What questions do y'all have for success for this course?
So one thing that, sorry, I was trying to find my unmute button, but one thing that I was wondering is, like, I notice in like classes like these, there's so many resources that it's not a lack of resources.
Yep.
It's deciding where to put my energy and time. And it sounds like you mentioned definitely the text was like a big one, but I didn't know if there was anywhere you like, if you thought like push came to shove, where we really should focus our energy to make it practical, considering having like 3 other classes and some people working and stuff.
Sure. So I think the voiceover PowerPoints are a great place to start at the beginning of the week. And even if like you are in a position where maybe you couldn't sit and watch them, like maybe if you're driving, please, if you're driving, do not sit and watch anything. But you can listen. You can listen to lectures. Then go back and watch them later on, maybe on chipmunk speed, to be able to pick up things that you're missing. The lectures in the yellow spiral bound book are essentially the VOPPs. So it's the same thing. The lab content, though, I would say, is out of S1 manual, and which is the exact same as the Ken Olson book. The only difference with the Ken Olson book is it may go into more wordy detail, It goes into more detail about the clinical practice guidelines, the ICF model, that type of stuff. But if you were to just focus on VOPPs and the yellow book, you'd be doing really well. Also, the 5 required readings for this course. Start learning them now. We should be able to talk about journal author year and what it's about. They're 5, only 5. There used to be a heck of a lot more. But if you start doing like one every couple weeks, and some are long, 2 of them are clinical practice guidelines. One's the clinical practice guidelines for low back pain and one's clinical practice guidelines for neck pain. They're like 30 some odd page documents. We don't expect you to memorize them, but how do you use them? What do you take away from them? What they do is they categorize patients. They look at research, and then based upon the research, they make recommendations for the best tests and measures to determine different treatment-based classifications. So is it someone with low back pain with a mobility deficit? It's like joint stiffness. Is it low back pain with a movement coordination dysfunction? Lack of neuromuscular control. Is it low back pain with radiating pain? And then how to treat those patients. Now, I'm not saying those are the only treatments you should do, or because you may decide for my patient, they need a bit more tweaking of an intervention than what the CPGs are recommending because of XYZ. They have an allergy to spicy red pepper. You got to modify it. Okay. So I would say focus on those things and start talking concepts out loud. This course, I would say, is a lot, but it's so fun to see your growth because you all grow so much in this class. And even though sometimes the spine examination treatment gets people very uncomfortable and they don't like it. Maybe they don't like it because it's not as clear as upper extremity, lower extremity, or not as simple as uninvolved versus involved. So you have to have a foundational knowledge of baseline in general. But the impact you can make on patients' quality of life is unbelievable. And you're going to be surprised at many individuals that you encounter, clinicians, aren't comfortable treating the spine. And you're on an internship, you're going to be leaps ahead of them because of what you know. And start talking out loud now. I can't say that enough.
Thank you.
You're welcome. What other questions do you have?
I think I have a quick question.
Please, Alex.
Dr. Grant, how do you determine, and you talked about talking out loud a lot, so like I understand that part of it. How do you determine when you're reading and doing content, doing voiceover PowerPoints, how much you're memorizing versus how much you're actually learning? Is there
Great question.
Yeah, that's
great question. So my brain needs different ways to test things. Help me understand. So what I like to do is I'll make up like matching games first, especially when you get into like syndromes. What I would do is I would take your 14-step sequence, and for every single syndrome you have in the back of your S1 book, I would fill out the 14-step grid. What goes in each category. Then I would cut those up into a piece of paper and then go like, okay, for this diagnosis, what things go underneath that in the different sequence? So the answers are in front of you, but you're kind of playing around with it. Some people like flashcards. I'm a notorious flashcard cheater. Meaning, if I can see, I can read backwards. So if I can see my pen through the note card, I'll read it. Cheater, cheater, cheater. So you need to know how you cheat yourself. Then it doesn't work. And also too, especially when you're not around someone to talk things out loud to, you become your own proctor. So in your phone, like in the recording option you have on your phone, you'd record yourself asking a question, then no notes around you, and record yourself answering the question. Then listen it back and critique yourself. If you're going to be in a car for a long time, what I like to do is make it even another step, is I would ask the question. I would then give a long break of silence to answer the question. And then I would record myself answering the question. So I can then listen to what I said back. If you're by yourself in a car for a long period of time, or studying with people who have no clue what you're talking about. anything you see in your notes that's a list, and the subcategorization from there, be able to talk about the list. And categorizing why it's important to know that. I think if you start to get some feelings behind what you're doing, we know that emotions and feelings help trigger our memory, long-term memory. So get happy about what you're doing, get excited, get angry at me, whatever, to trigger feelings, to help things connect deeper. And I also think don't study for such long stints of time without taking a break, right? It's kind of like if you're reading a book and you're like, well, I've read the same page 5 times and I don't know anything. That was useless. So that's your body saying, this is not effective studying. Move on, find something different. So maybe taking that time that you decide, I'm going to spend an hour working on spine today. We're going to cover just these 3 topics. And maybe you read over it, take some notes on if you like, highlight, find what ways work for you. If you're someone that highlights every single thing you read, I'm not sure highlighting is then effective. If you're writing down everything that you're reading for your notes, that's also probably not effective for true learning. And then go back and tackle it a different way. So maybe you've read your notes and have some key questions. Go back and answer those key questions. And then talk them out. Even if you're just reading your notes, you're talking out loud and you're hearing, you're listening. That's going to make a big difference. And then later on, have someone ask you questions. And explain it to anyone that will listen. I kid you not. The person at the grocery store checking you out. Explain to them why they need to have good posture while they're checking out your groceries. Explain to the person stocking the canned goods section why their body mechanics are rather crappy and they need to modify and do things a bit differently for their spine health. So anyone that will all listen to you, explain, teach, because that shows that you've learned it and not just memorized it. And that's why like funny things like doing the facet planes with your hands. Do them. That way you're not memorizing. Like you can always do the facets. Do the dermatome dance, do the myotome dance to make it so it's just a habit. If you feel that dermatomes and myotomes are just this nebulous and not sticking in your brain, then every single morning, write them out. It takes 2 minutes, but do it. That way you just get in the habit of force yourself to shove it in there, to make it stick. Yep, and make it fun. Like I think it'd be cool like if you guys like were to message each other during the day, voice messages, like oral exam questions. Why not? It's fantastic. Makes it fun. Then they can voice message you back. That help, Alex?
Yeah, of course. Thank you.
But know how you cheat. Like how you cheat yourself. And especially like if you also too, like the kiss of death to me is when you're like, yeah, I know that. Fine, prove it. So if you tell yourself, yeah, I know that, make yourself prove it to yourself. Give yourself a mini oral exam, record yourself answering the question you told yourself you knew, and see if you really do. And if you don't, and if you're all of a sudden you're fumbling over your words and you're sounding like a Martian from another planet, you don't know it well enough. Other questions? Alrighty. Well, you all rock for being here. Thank you for taking time out of your busy schedule. I wish you much success this term and the rest of your career at USA. And I'll be back in a few weeks to do the midterm concept review. We'll go actually over cases. We'll do a Kahoot, fun things like that for the midterm exam. So bring your friends. And then I'll see you again for the final. Much success. You got this. Good night.
Thank you, Dr. Grant.
Thank you so much.
Dr. Grant.
You're so welcome.